but just could we get better at this? Can you catch that CQI approach? Can we get better at this? And I think it's important that you look at your internal. And I heard that talked about a bit in the discussion this morning, but I think again, as leaders, look at your internal, particularly if there are staff issues or program issues. Try to really get to the core of those and resolve them, because I think it's important. Behavior, attitude, if those are the issues to resolve. I think particularly if there are those issues which are keeping other people from doing their job appropriately. Be sure to be mindful of that. The other thing I would encourage you, in a clinically trained staff world that we're in, sometimes we tend to provide clinical approaches to supervision, and sometimes that doesn't work very well. It works beautifully well appropriately with clients and families, but sometimes when we have supervision and supervisors who tend to use a clinical approach, example, one system, I'll give you two examples. One of the systems I work with is in Georgia, and they called me in because this one LCSW had not signed a single treatment plan in 18 months. And she owed back, I think it was $144,000 in audit. And so the director wanted me to find out why the supervisor of that clinician didn't do something about it, or did they know about it. And so I met with this clinician supervisor, and I said, let's go back, this was in January, December, let's go back to January. I said, did you know that she was not signing treatment plans this past January? She said, yes. And I said, well, why didn't you do something about it? And she said, well, her husband stumped his toe, lost his toenail, was out of work for 5 days, and I didn't have the heart to tell her because she was so emotional about it. Well, and I said, let's talk about February. And in February, well, her son was dismissed from school for disciplinary reasons for 3 days or whatever, and she was so emotional, I just didn't have the heart to talk to her about it. Now, I went through the whole year, and every month there was another reason that she could not hold the staff accountable to honor federal and state law to bill appropriately for Medicaid. Because it was really a law issue, this is a legal issue. That's what I mean by fair. It's like we're so involved that we can't see the black and white of supervision. Another one is, when I got to Cumberland County, we had one staff who constantly was late for work, constantly, and was in a very important role in the agency, a triage specialist, so we needed her there. And it's a clinical position. And so I finally talked with the supervisor. I said, why is this person running late? And the answer is, well, I'm working with her, but she and her spouse are feuding over who's going to get the car. And I said, so how long has the feud gone on? He said, well, we're working on it for about 6 months, but I think it's getting a little better. And I said, we have an EAP contract, don't we? And he said, yes. I said, if she needs therapy, then you need to refer her to our EAP contract. That's not your job. Your job is not to be her therapist or her couples therapist. That is not your role, because you play a role. And I said, the second thing is we need to tell her if she needs to get a ride from other employees, take a taxi, or get a car from her spouse who they are feuding over. It doesn't matter. She has to be at work on time. But we're not going to keep talking about it for months, as we have been, because it's not doing any good. Is everybody with me? See, that's what I mean by supervision. It has to be that you're looking at what is the role, and what is the role the organization needs for that person. Certainly care, but I can't carry this on for months at a time, trying to solve something that may not be solvable, or certainly for me as their manager or their supervisor. What I want to talk about this afternoon is this whole concept of where you're going with this new proposal or this new clinical, specialty consultation. What we did is we issued to your agency, at your request, a proposal from our team, and let me introduce you to Joy. Joy is this person right here that I'm highlighting, Joy Fruit. Joy is an MSW. Her primary background has been both in behavioral, but also has been in primary care as a care coordinator, care manager, and also a practice manager. She will be working with you on several models of change, and let me go through this with you and pull up the actual slides, because I pulled those together for you, so I didn't have to go through the narrative. The key thing that we're going to try to do is the project scope is to really try to sit with you. As I said this morning, Joy has been trained, as she's worked on this now for several years, along with Scott Lloyd on our team, Annie Juvie on our team out of Missouri. But she would want to meet by internet. I think she's coming on site on the 12th. Is it the 12th? It's next week, I think it's the 12th. I'm just, it's my date in my head. But she will come on site and talk with you about what is going to happen. But she also needs for you to do some preparation, which I assume she's been talking about in terms of the right people at the table. And I want to go through what those right people are. What we ask is, we're going to try to assess, as you can see here, from the throughput times, from the time a person calls you or family for routine care. We're not looking at crisis at first, we're just saying for routine need. What happens? From that moment, the phone call is received, the triage screener gets the call, or what happens? And then we're going to go through a process of flow charting. And she will do this as your team members talk. And so what we want are all of the clerical, clinical, finance, admin, whomever those staff persons are. And it may be specific to a location, like your location in this county would be different than this location. And so she would do both of those and give you the difference between the locations. But she needs the people who actually do the work. What we don't need are managers. Does that make sense? And the reason for that is that, unless you do work, is that we don't want the staff to not be free to tell us what is really happening. It's like if you were working with a client, you really want the family to tell you about the child, really what's happening, as opposed to, well, it's okay and everything's fine. What we really want to know is if this is happening or not. If it's not good or bad, again, this is not about getting anyone into trouble, is to be able to report back to you, and I'll show you some of the tools, what the costs are and the process variances are. And Joy is very good at picking up what we call ghost or double assessments, which means we're doing it here and then we're doing it again. And Joanne mentioned this morning, we're answering, getting question information here, and then we're doing it again here. She's going to start picking up on that redundancy. Because that's also going to be tied to her time it takes and to the cost involved in that time. So she'll be working with you on that. But as she goes through this, she's going to look at your average cost, the number of processes, number one, by program unit to location. Number two, what's the cost of it? And she'll give it to you in dollars and cents. And she can break it down by segment time, or she can break it down by process. And what she will give you are those numbers. Now, what we have are national standard costs of salaries and fringe overhead. If you do have your own salary, fringe, and overhead costs per position, that would be helpful for her to get that information. If not, we just use national averages. Or if you want to look at that and say, no, ours are a little bit higher, ours are a little bit lower. But we will agree on what those costs will be. Because we're going to cost out every minute of everybody's time, regardless of whether they're clinical, clerical, admin, or whomever works with the client. And whatever they do for the client, getting them into treatment. Make sense, everyone? So that will look something like, let me go forward with this to show you a little bit. But it looks something forward like that. This is an example of a flow chart. And the flow chart is not good or bad. Please, this is not again about good or bad, but what we're trying to do in this particular center, there was a red flow and a black flow. There were two different processes on the left and on the right. What we try to do is identify in this flow process, like this is a residential case manager, what forms were being filled out. What did we do at what stage of the process? And if they came in, it was no, what percent of the time did that happen? If it was yes, what percent of the time did that happen? What was the wait time in days or hours? So we're really going to get that specific with the staff. Again, not good or bad. Yes, please.
So just so I may answer the question that's brewing for me, she'll only be looking at the programs and services where there are treatment plans developed because we've been managing.
No, it's basically into treatment. Now, if you define that as treatment plan developed, but if you're inheriting a treatment plan, is that what you're doing?
Well, I'm thinking about some of our other
Yeah,
community
early
services.
intervention prevention. Yeah,
Yeah, we're not.
Well, again, the question is for you. And if it's into service, meaning if you feel like there's some challenges there or there's some areas that you want her to look at, that's what her job is. And she has the time to do that. We typically figure 5 to 8 processes. So if it's into service, means it's not a treatment plan, it's not an assessment, but we bring them in and we do this, this, and this. And what are those functions? How much time is it taking? Who's doing it? So again, remember that we need to be coordinated with Joy when she comes is aware, and I'll make her aware too. If you can jot down those programs, if you don't mind, and give it to me, then I'll email Joy about those to make sure. But I would say anything that concerns you about access to service, access to treatment, access to care, whatever terminology you want to use. And the purpose here is not, again, the purpose here is to allow you to have some information presented back to you. The whole purpose of this is to get all the assessment done, to get it right back to you and say, here's what we're seeing. For instance, here are the flow charts. For example, to give you some idea of how challenging this process is, with 15 centers in our integrated healthcare providers running collaborative who wanted to bring primary care in, they had 191 different process flows to bring people to care. And that could be for residential, it could be for outpatient, it could be for group home, it could be for any number, but they had 191 ways. The problem with that is what? Now I'm going to add primary care to it. So which one of the 191 ways do I add primary care to? So if I've got all this divergence or all this multiplicity of ways, then how do I build it? The other thing is the staff time. From a half hour for methadone clinic to 11.7 staff hours. So if I've got a person spending 12 hours, that's clerical clinical, to get someone into care, how much is that costing me? It's about $855. So what am I getting as an income to offset that cost? So what you're looking at is not only timeliness, but is it effective from a cost revenue standpoint? Does that make sense, everyone? So we're going to start with the basics of just going through the processes. Let me come back again to that chart. We're going to go through the processes and identify. And who's going to identify? The staff who do the process. Okay? So she can do 2 of these in one 2-hour setting. So if we want to do the outpatient programs, and if we want to do the other, if it's a residential referral, we'll do those the next time she meets with them, but it's all by internet. So again, what we need is just those team members, and I'll show you what they need to know to kind of figure out to give you her information. Okay? But they will tell her, she will draw it on the spot. She'll say, is this what you're telling me? Is this right? Is this correct? But she will verify the flow chart before she signs off. That everybody at the table has agreed this is kind of representative. Then from there, she takes it into a cost finding exercise. We built the calculators for that. So she'll take process 1. She'll look at the client fills out an intake packet, an intake coordinator role. The salary fringe cost per hour $17.39 if that's their salary fringe. How much time you're spending with the client, how much post time, and what's your total cost. So in essence, we can come up with the costing for the first process, second process, third process, depends on how many processes you have. Most teams have 4 to 5 processes. Very few have 2. 2 processes a day would be assessment and treatment plan done in the first hour and 20 minutes. Treatment is the next process. They're in treatment because the plan's already done. And that's what we call same day, and they're into treatment. So again, most of them are 4 to 5 processes. So they'll cost it out, and then they'll give you basically a summary. Let me come back to that, sorry. Let me come back to that. I think I need to drop these down. They'll give you a summary of what it looks like per process. And let me pull up one of those, right here. They'll give you, for the outpatient, or for a county, for a location, whatever you want her to define, they'll give you the process in terms of staff hours, client time hours, because we're going to ask how much time does the client need to be there. We're going to ask also what's the cost, and then what's the day's wait, meaning from the first time contact to in service, in treatment, whatever you define, is how many days is it. And then we're going to give that to you for each of your locations to ask you to identify a process that is standardized, that reduces the time, reduces the cost. Does that make sense? Okay. Questions about that? So you're going to be given graphical evidence of here's what we found. And for each one of those processes you want her to mention. Okay? And she'll give you a written report, which I'm reading from for the statewide stuff this morning, but she'll give you a written report on here's what we found and here's our recommendations. The other thing she's going to do, and by the way, these are typical standards that we recommend, is the gold standard for access for an agency is 1 process. Now, if you have multiple programs and they don't go through an outpatient role, but they go through this, then it's 1 per. That would be silver. 1 per type, 1 per division. But I don't want to have residential programs have multiple processes. Does that make sense? Why? Because EMRs can't support it, and it's also hard when I go to a referral agency and say, but by the way, we want your referrals for residential, but here are the 5 different ways we're going to bring them into care. I really need to give them a way. And I'm going to show you that concept. I want to hand them that flow chart. I want to hand them the time. And you need to know your cost. The important thing, too, is that with 1 process, you can then refine it. With multiples, the question is, which one are you going to refine? And that's what we're really facing right now. Typically, we want a range of 2 to 2.5 hours total. First call for help to treatment, in treatment, 2 to 2.5 hours of staff time. Clerical, clinical, everyone. We need to get them into treatment. And the cost range needs to be $100 to $150. $150 to $200. That's typically what we get paid. So we're trying to peg it back to what we're getting paid. And then the next performance is 8 days or 10 days, which I'll go over here in a minute. But the key thing here is she's going to give you your numbers tied to what we see as national standard, what's working. How do you do it? So you're given evidence, objective-based evidence. This is where you are. What are you going to do about it? And your job as leadership is to say, we're going to have another team, and I'll pull those teams in a minute, to say we're going to come together and come up with a new model, or a community model. Now, if you have a model that's working in one location, that's working well within the parameters of national standard, you may just want to adopt that model instead of trying to upend everything. Okay? So when you look at these teams, there are going to be a couple of teams. And by the way, why is this important? She's also going to, let me give you this. She's also going to do a data management review. She's going to take every data point that you ask and put it into a spreadsheet. And she's going to basically say, we ask for name here, name here, name here. Here are the processes, vertical. So we got this, and they go to here, they go to here, they go to here. We ask their age. And so we ask their date of birth. The question is, why are we doing that? And so she's going to basically give you a count of total data elements you're collecting per process. In this case, this is out of Illinois. 1,854 questions were asked, of which 564, number 2, were redundant. Okay? The question is, why are we doing that? And that's going to be breaking down this, because what Joy is going to really work with you on in our model is you have a horizontal process. What we tend to have built over the years are vertical sub-processes. They get their financial stuff down here. Then we send them over here and we get the consent stuff. And then we send them over here. And so everybody wants different information or the same information just in a different place. So how do we get beyond that, if that makes sense? Okay? So she'll give you that. And then the question in Illinois, 957 data elements that were CARF agency were required for CARF accreditation in the state. So they were asking a net of 1,300 questions. So we went from a 4-hour, 10-minute process to an hour and 20. Everybody understand the concept? Now, this is an example of a consortium. And if you're multiple locations, you're somewhat like a consortium. Because if you do things at different counties or different sites, these 6 community service boards in Georgia had 29 different processes. The average center we work with, 3 to 5. The most we've ever had in one center in Pennsylvania was 19 different service delivery intake processes. So in essence, depending on whether you went to this county, whether you're adult, your child, substance use, mental health, whatever your needs were, you had so many different ways to come into treatment. And so what we did is they were actually collecting 2,700 data elements. The state required in Georgia 975. So the rest of those were things we did to ourselves. Okay? And this is where, Sue wanted to, remember Judy this morning with the blue form on yellow paper, the yellow form on blue paper? Same concept. They went to one IT solution to save $1 million. But more importantly, if you go to any of those now 8 agencies, they've expanded their consortium to 8. This is what they hand the referral source. This is their intake process for any agency, regardless of your need. If you're adult, child, substance use, mental health, even IDD, because they serve IDD, this is how you withdraw them. Everybody with me? Can you see the power in that? This is how we will bring you in. This is the time. This is our data mapping. So they went to an electronic record company and said, these are how we want our data elements assembled. This is how we want them appear. This is what we want to do across the agencies. And this is in this flow chart where we will collect all this data and who will collect it. So they were actually able to save $1 million instead of all 6 or 8 of them creating their own little medical record. Okay? Thoughts about that?
I have a
Yes,
question.
please.
If you look at our mental health assessment, the way it's organized, it's horrendous. Anything anyone can do to help us simplify it, I think would be hugely advantageous both clinically, and I think it'd be a tremendous satisfier. It would save a lot of wasted money. It's the right thing to do. One of the things, though, that I think is important is that somewhere in an assessment, someone takes all the data points and makes a cogent sentence or two about the meaning of it in total. Is that going to be possible in the new world?
I think it will. I think the question is, where do you put it within the assessment document? And I think the problem we've had is the old clinical interpretive summary or integrated summaries. When you read them, they're so subjective, you really can't build treatment plans from them. It's very hard to say what goal and objectives do I need to meet the needs of this client from the subjective nature of the clinical interpretive summary. So most of the teams, and that's what we did with the SoQuick initiative here, we've done it in New York, standardized, Massachusetts, Oregon, is you come beyond that one more step to say, out of all of this, what are the specific needs of this person?
Right.
And how do we identify those, which then become the basis of the need, becomes the basis of the goal, medical necessity is met, and what objectives and strategies or interventions will we provide. So I think, again, it's just the next step that has to happen, but you do need that interpretive summary in a much more objective way. Now, the DLA 20 is being used in those states I mentioned for that very purpose. Anything 4 or less rated on a functioning scale, 1, 2, 3, 4, is with severe impairment or need, then that becomes a focus of the goal at the end. So there's pops like that at the end. Qualifax, I don't know, what system do you all use?
Site consult?
Okay, but Qualifax is just licensed the DLA 20, and that's Smart's licensing it too, but they're building it into their assessment so that as you go through the assessment, you're looking at the DLA 20 elements, and then it summarizes them at the end and says, these 4 have been identified at 1 to 4 ratings, so these are focuses for me. So it actually does it for you as you go through it, and I can show you a sample of that.
That's very nice.
But I think that's the tools we're going to have to be much more focused and objective. The key thing with Joy is that she's going to try to work with you on the processes. If she starts to see in your assessment that it's overwhelming, then she's going to make recommendations on what you need to do. Particularly if there's redundancy, where we see redundant collection. We collect it again, collect it again, collect it again. Joy came up with this assessment and a half nomenclature with one team, but they literally, in their screening and triage, they were doing a half assessment. Then they referred the client in, and guess what they did? A whole new assessment, never used any of the information. So the point that she made is, why are you doing this? I mean, what do you need to know in a screening triage sense to look at the level of acuity, level of need, but not to get into all this history, because that's what your assessment clinician should be doing. But, she's very good at trying to sort through why are we doing it and why are we going overboard here. Those are questions. Other thoughts or questions?
David?
Yes, please.
Would Joy be the right person to look at like a possibility of like an interim treatment plan? To address
She can
that
be. Also,
scenario?
Bill's.
So it gets us started, it gets us, we have our medical necessity, it gets our cases filled, but then it gives the team more time to, like you said, collect more history of their behaviors and different programs.
And I think particularly if you're getting a lot of information from referral sources post, you're getting it kind of dribbles in, so to speak. You really don't know the day you do the assessment, but you get it a week later, 2 weeks later, a month later. The assessment update is a wonderful tool which ties to your initial plan or interim plan, where you basically are doing assessment, interim plan in one function, and then you're looking at assessment updates as you learn more from the referral sources and or from the consumer family who tell you more, the second visit, the third visit, and then that comes back into an updated plan or a final plan. But I think all of those processes, we have worked on those for years with other states. Joy will be helpful with that. Bill Smelter on our team. And so the good news about our team, myself, if there's a question, if Joy doesn't feel that she needs to focus on, she'll get it to a team member and get you an answer. That's why we think, the advantage of having our team is having different expertise areas, certainly, but all of us are able to fill in when we need to about a specific area. But on interim, to me, the gold standard today is an hour and 20-minute assessment and treatment plan. And when they walk out in an hour and 20 minutes, we've assessed their needs, we've identified what their needs are, we've got a goal objective, 1 or 2 in place, and they're in treatment. I mean, it's not about starting over next week when they come back in. They're in treatment. And as we learn more, we expand what we know. We expand what we're treating, but we know what we know today. And I think that's a model that she would advocate for. Annie Judy on our team also in an integrated setting. She's a health home out of a health home system in Missouri. but she does the same thing with physical and behavioral. So again, looking at those kinds of things, if y'all need to discuss that in terms of your moving into more of a wellness book. Other questions? Okay. Now, let me go over and give you a couple of thoughts about this proposal so that you will have those. The first team that we're going to have is a GAP team, or a gap analysis. That is the team that we need for those different programs. For instance, if you want to look at a referral program that's particularly for you, then we need the staff who do that. If you look at an outpatient focus at location 1, we need the staff that are doing that who will be representative on that team. These are the persons who really do present the information to Joy. Okay, that's that base level. What they need on this analysis is they need to quantify the client time, staff time, and cost. Now, please don't get hung up on cost, because a lot of our staff, would you agree, don't know the cost. So if you don't know the cost, Joy will use national standards and plug those in so we can get back and say, here's what the average is. Do you want to look at these costs differently? Do you have any other information? So the staff don't have to be CPAs there. They don't have to know cost. It's just that if they do know it, it will be very helpful for Joy. Okay? We're going to try to have them tell us about bottlenecks. We're going to tell us about solutions. And what do you think might happen if we did it this way? So we're going to start doing that. They need to know, and this is important, your no-shows. I've already had 2 discussions with team members at the break about your medical services, your telehealth services, where people just aren't showing up at a pretty high level. So what are those rates like? If you have people come in for a particular function, how many of them are not coming back? So any of that information could be very important, because we're looking there at cost. Net reimbursements, intake counts, meaning if we do this process, how many do we do a month? How many do we do a year? Because then what we're going to do is project that out. If you actually have a cost loss per event, and you're doing 100 of them a month, here's what your cost loss is per year. Everybody follow what I'm saying? So if they know those counts, and in some cases they don't, but what we'll ask them to do is, after a meeting today, can you go back and try to ascertain the count? Can you go back and look at the last month or last 3 months and tell us about how many people came in through this process? So again, we're not trying to put them on the spot. We're just asking for information. And then wait times. If they can be kind of realistic about, well, once we do this, then they usually wait 1 day, they wait 3 days, they wait 2 weeks. What is the typical wait time between processes or contacts? That's also very helpful to let you see your total time. Because there are 3 metrics involved: the process and flow, and what you're doing in collecting, the cost of all of that, and then the time frame for all of that. From first call to finish of in care or in treatment, whatever you define. So that time frame is tied to the wait times. How much time it's taking to do it when they're here, but between this function and that next process, are they waiting a week to get to that process? Everybody with me? Okay? And then the rapid cycle change team, they will do kickoff, and that's what she's going to do. What they're going to start looking at is she's going to start looking with you at collaborative documentation. This is a very important one if your staff are struggling getting documentation in on time. She's going to work with you on walk-in, same day. What does it look like? How does it work? She's going to look at no-show management policies and procedures with you, and she's going to review and look at your utilization management around this concept that we'll talk about that in the last session, around distributed justice ethical demands. Meaning, are we continuing to schedule people who are not coming to treatment while we tell people who are coming to treatment today we can't get you in? And that's an ethical dilemma. Everybody with me? And so we're going to have to start looking at that ethical dilemma, because we tend to schedule people again as a default, as opposed to engage them or get them involved in either re-engaging in treatment or to transition. But we can't just keep scheduling. And so she will have that for you as a function. Out of all of this, though, back to the project timelines, she's looking at, and again, the rapid cycle change work and your gap analysis, she's really looking at 1 to 2 months for gaps. So she'll start that, and in 2 months she'll know your costs and your breakdown. And then the question is, back to your specialty consult, which is part of it is needed today, but your complete this rapid cycle changes, what do you want to do about it? So she's building in here another 5 months or so to say, how do we come up with a solution, how do we implement, how do we test it? Could be Joy, or it could be, oh yes, in terms of your team, yes. Because your GAT team is really going to identify an assessment, a data assessment point. Once we find it, we're going to present it back to leadership, and then you need to tell us who you want as leadership to develop a new model, different model, and to support the implementation of that model.
Can you talk a little more about the big impacts that you see made in organizations like Beech that have done this well?
In terms of outcomes, absolutely. Example here, and I'll give you this is from a national study, but what we did with same-day access grants, for instance, Centerpoint out in Lincoln, Nebraska, reduced their wait times 91%. So these are wait time metrics. And all of these, we averaged 50% wait time reduction. So if they started out with 15 days or 20 days, we could cut it to 7.5 to 10 days total time. Access, though, is always same day. So we're still trying to get to same day using these metrics right here. Let me go back to that, which I didn't cover those. And I'm going to give you one other example to answer your question. But the access metrics would be here, is that what we recommend for you is primary access is the day they call, same day. We have a centralized and a decentralized model. Joy can work with you on that. Centralized means you have more than 100 intakes a month. You can standardize it with a centralized function. If you have less than that, an off-site location has 20 a month, then you would have a decentralized model. We work with you on how to set up the decentralized model, so that you're really not open for access every single day, but you're open for access on the times that clients are contacting you. For instance, are they calling you on Monday morning? They calling you on Tuesday afternoon. So when are they calling you is the metric that we measure for help, or when they're walking in. That's where we build the same day capacity, when the majority of people are calling and walking in. Does that make sense? So you're not just doing it all day long because you don't have enough clinical capacity. Okay? So the primary. The secondary is within 3 to 5 days. And I'm going to go to an outcome study right now in Intercommunity, but they're offering same-day therapy and same-day case management right now after intake. So they have an hour 20-minute intake assessment and treatment plan. They can get them into a group therapy group that afternoon, or they can get them into case management, care management, they're calling it, that same day, or no less than 24 hours later. So what they're trying to do, back to a hospital setting, Dale, is once we identify what the needs are, we're trying to get them to engage into care that moment or that day or within 3 to 5 days. At Astor Behavioral Child Adolescent Agency in Bronx, I don't have this slide up, but what they found is that from the intake date, if they could offer them treatment, that's therapy in case management, in 3 days, 94% of the family clients showed up. If they offered it in 5 days, 92% showed up. If they went into 8 days, it dropped to 89%. And when they went to 22 days, they dropped 50% of the clients didn't show up. Everybody catch that? So this concept of capturing and engaging them when the need has been identified and timing is critical. The same thing is true. What they found in Astor is they wanted the same day and 3 days for their clinical second appointment, and tertiary 5 days for their doctors. They were running 90% show rates in 5 days on doctors. But if they got out 20 days on doctors, they were dropping right back down to what the other normal national averages are. They were dropping to 30% no-show, 40% no-show. So the concept of your being able to not only open the front door, but build a secondary and tertiary capacity is what Joyce will also be talking to you about. Everybody understand what I mean by secondary and tertiary? Medical and clinical. And that could be case management, you support as well as therapy, depends on what their service needs are. So the key thing here is it's time. It's absolutely time. And what we've done now enough is if you look at the data points and look at this as an example, there's about 27,000 intake appointments on this data point for a grant. But the green at the bottom, the 0 is the day they call. Let me get my pointer, sorry. 0 is the day the person called or walked in for help. 65 days is over here on the right. The red is no-show, yellow is canceled by client, and green is they showed up. But what you start to see, even if they call us today and say, I want to come in, we find that only about 94% on average will show up today. As soon as they get off the phone, something happens, the ride didn't work out, somebody walked in and they got a phone call. It just didn't happen. So it's not 100% if they say, well, come in together. You find about 94, 96. But look at what happens when you get to day 3 and 4 and 5 and 6 and 10. You start to see the cap rate here drops dramatically. And if you look at the total trend, because there are different data points on each one of these, but as you look at the total trend, the longer we wait in any of these processes, the more they drop out. So the question, let's go back now to this morning's discussion about value. Remember value, not volume? So we're no longer going to do volume of services, we're going to do value. So how do we produce value? They've got to be in treatment. Make sense? If they're not coming, we can't serve. And we're not serving. We're not providing the intervention. So to get them in time when you get that value is important.
And just to link it to this morning in a different way too, I think it's one of the key measures that managed care companies have to meet is having someone who's been discharged from a kid or adult, discharged from a psych hospitalization has to be seen within 7 days in the community. And so one thing we can take to them, we have immediate access for psychiatry and counseling. We can go to them, we can say, we can help you meet this. And every one of the Ohio managed care plans this year lost money because they failed on that indicator, and so they took money out of their payment. So that's yet another reason. And I'm sure that the reason that's one of the keyest measures is because people do get, if they get there within the first week, they'll engage in treatment. Otherwise, they're more likely to jump back into a psych hospitalization.
And I would say this is important because what we're finding, in terms of just outcomes from systems, and let me give you some of that, I know that was a question earlier, is I wrote an article, I'm glad to give you the article, it's being published in the National Council of News, but it's called Intercommunity out of East Hartford, Connecticut. But let me pull that up. Help me, I believe that's in my training folder. Let's see. Yeah. Make that larger for you. But what we did is we started with this team, and they had a major concern in the community. The major concern was that they were not getting people in time. In Connecticut, they have a health home. Let me make that larger for you. Sorry, I'm sure you can't read that in the back. Is that better?
Yes.
Is that better?
Yes.
Okay, very good. But basically what they had is they have, if you will, a community mental health center authority, and that's CMHCA. The CMHCA's, which they are one of the smallest, by the way, is that they are the only ones that can become health homes in their state. So you have to be a mental health authority. You can't just be a provider to be able to become and qualify for a health home status. The problem they had is they couldn't get people in, and they wanted to partner with an FQHC. They couldn't partner, and we talked about this a bit this morning, but they would go to the FQHC and say, we really want to partner with you and help you, and they say, well, what can you help us do? And the answer is, we can't get people in, but we want to help. Everybody with me? That's not going to sell, by the way. It doesn't sell real well in Detroit or anywhere else. So what they found is they couldn't be helped. So they came to me and to us and said, we've got to change. And what they had up here on the left is on their front door, their initial assessment, they were running about 48 to 50% no-shows. This is quarter 2, quarter 3, quarter 4 of 11. In quarter 1 of 12, we moved to same-day access. Front door, okay? Now look at what happened. They went from 42 intakes completed in January, February, March, April, May, and June of 11. Hosts going to same day, here are the numbers they have actually provided same day. It's a 90% increase in intakes. Now where did they get those intakes? Other behavioral health clients at other centers out of Hartford, but guess where? Primary care practices. In fact, if you look at their outcome data, I want you to look at this, and this is important, and I'm going to talk about how we got secondary access managed as well. But when you look at this, and you come to this paragraph right here, they basically provides 550,000 services, 3,000 child and adolescents. They're CARF accredited, Same day for clinical evaluations, including individualized treatment plan and ongoing treatment team. That was same day, 1 hour a week. They met medication quotes within 72 hours and walk-in therapy with care management 5 days a week. So if you got any care management, case management, they call it care management, come on in, we got you, okay? Now, look at what's happened. They've increased their access to quality service that led to a decrease in ER visits and hospitalizations over the 3 years of 3.7 million. So what's my message to a hospital system? Why would a hospital system be interested in me? I can divert. Monarch in North Carolina diverted 27% of the emergency room visits. Now, what did they do? When they did the same-day access, they had every client surveyed, and they said, if you couldn't have gotten in today for access to see, because they said the doctor same day, would you have gone to the ER? The answer is yes. So they diverted 27% of several thousand clients away from the ER. So if I'm going to partner with a hospital, I'm going to take them real data. Does that make sense? And say, this is what we're doing with conversion. The third-party revenues are up 40%. Now, why? They become a preferred provider for third party. Now, why are they preferred? Right there. Get it? And if I'm at risk for that beneficiary of insurance or third party, yeah, I want them in today, and I want to see a care manager today, and I want to see a doctor in 72. Yeah, I'll send them there. Can y'all see the concept? Okay? Now, more importantly, look at what's happened. And this is important, team. They increased their intakes by 90% with the same staff. They've increased their 66% medical with the same staff and 45% increase in clinical. Okay? Now, how did they do that? And here's the answer. Here's your answer right here. This is important. This is called substitute process, but if you look at this chart right here, when they started the process back in 2011, their clinical services, that's therapy, non-medical, therapy, case management, ran 42% no-show rate. So every day we scheduled, and every day 42% of the clients on average didn't show. So we had the staff there. We employed the staff. We had to build it. Everybody with me? Everybody familiar with this? How they built the capacity to serve more people is they cut that to 10%. By engaging clients. By engaging them today with a treatment plan today, getting them into service today or tomorrow or this week, you'll be in service. And it's not 2 weeks or 3 weeks. Medical services running 46% combined psych evals and follow-up meds, 46% no show, they're at 6%. But then they've also looked at the number of people in 2 quarters, 6 months of 11, 12, and 13 that they served with the same staff. And all we did was take away the no-show by not scheduling clients out 6 and 9 weeks. Everybody with me? And then client satisfaction. The other thing is their cycle valves. When we started in 11, they had 116 days to get to a cycle valve, and now they're at 72 hours. So back to your requirement, Deborah mentioned, is I've got to see someone 7 days post-discharge. They can see it. Okay. Questions about that?
Yeah, I have a question. What's the average length of stay in this kind of outpatient model for behavioral health?
Depends on the payer. If you've got a third party, if you're running 31% third party, you know what they're going to give you is so many visits, so many days. And after that, they're going to look at review and they may want you to discharge. If you're looking at Medicaid, depends again. If you've got MCOs now managing you, such as in Kansas, they're giving them 10 hours of therapy a year, individual, a year, and that's all they get. So the MCO is now dictating on therapy, here's all you're going to get, so what are you going to do with it? So it's not about only have 10 hours. The point then clinically is we have 10 hours, what can we accomplish?
Right.
So then you go to brief therapy models, motivational interviewing models, you go to different therapy models than the old long-term, 25 years of therapy. So it depends on the payer and the state. If you're still in grant funding, a large piece of grant, they have no medical necessity per se, and you're just going to keep paying you, whatever you want to do. Does that make sense?
Yeah, I was thinking about it in terms of some of the evidence-based practice models that we're implementing. There are probably not going to be enough resources in terms of reimbursement to keep them going.
I think you're totally right on target, and I think the challenge we're going to have as practitioners is to demonstrate why this evidence-based practice should be approved for more intervention. And why, and it can't be, I think it's better. I've got to show them now.
Sure.
I've got to, and that's our next topic. I have to demonstrate people are functioning better, getting better with this model versus what you're willing to fund. And that's what they're doing. I know in Kansas we had to show data around the fact that people are getting better, but how much more service they needed to get there. So they were able to get the MCOs to back off on some of that, particularly if you start to, how can I say this, politically approach your Medicaid office in your state. You know, this is about these MCOs really trying to hammer us down on utilization. It's not about trying to get people to get better. We're trying to help people get better. So if you can stand on the quality leg with data, but it can't be, I think people like this a lot better. You know, I was working with a child team recently, and they had a very intense therapeutic encounter evidence-based practice. It was basically 4 clients per therapist. They had a caseload of 4, and they had 6 staff in this evidence-based practice. They had 24 clients in this intense program. So I started looking at it with them I was looking at their data, utilization data. And so I was asking the manager, I said, so how's this practice going? He said, oh, we have high fidelity. And I said, well, okay, tell me what's your fidelity? He said, well, we meet every morning, state requires it. We have all the reports, we get them all in on time. And I said, so how do you think the clients are doing? He said, well, what do you mean? I said, well, is this intense approach working for them? He said, well, I don't know. He said, yeah, I'd say it's working for them. And I said, so how much service do you think the average clients get in this intense program? Because if you have 4 clients for a clinician, you better be giving 25 hours or so per person. Would y'all agree? On a 170-hour work week. Guess how many hours on average those 24 clients were getting in direct service? 9 hours. So what we have is an intense program that is filled with meetings and fidelity that has nothing to do with the intensity the program was originally designed to do clinical. Nor do they have one outcome to demonstrate that people were getting better. So my point is, in that model, that's indefensible. I don't think any payer will pay you for it unless you can demonstrate that having 4 clients and giving them an average of 25 hours of service will help them do what? As opposed to, in fact, this manager didn't even know how many hours of services clinicians were providing. They were just real busy with fidelity. Real busy. I think that's our challenge. That's going to be our challenge now.
So, Lloyd's analysis, and I may have missed this, I was distracted for a few minutes, but does she look at when are people saying they want appointments who then have to wait longer because they can't get in before 7 at night and the 7, 8, and 9 appointments are scheduled for 3 weeks or something? Does she look at that kind of detail?
I would say that she needs to, based on what I'm hearing. Yeah. I think so. That, meaning, when are people calling you? We have calculators for that. We can give you and let you have front desk manage that for, it doesn't take forever. You know, 22 work days. It's managed when people call. It's called first call for help calculator. Are they calling us between 8 and 10 in the morning, Monday, 10 and 12, 12 and 2, 2 and 4, or after 4? So those are typical 2-hour segments. Are we open in the evening? Do we have people's ability to call? On our hotline, how many people are calling our hotline after 5? You know, those are questions. Thursday night, Friday is a very important question. So do we need to look at altering hours to meet those needs as opposed to waiting until the next day? If we have on-call staff doing crisis intervention or on-call at night, how many times are they going out at night? And those are questions I think that data points could be very helpful to inform.
This is jumping ahead and has an assumption built in it, but assuming people need more night and weekend appointments, and assuming that clinical staff don't want to be working nights and weekends, at least not predominantly. Do you all work with the organization to help them convince the clinician, or is there a way to structure their jobs so that access is possible?
Absolutely.
Living and going somewhere else?
Absolutely. Because here's what happened when we went to nighttime operation in '93, because we just couldn't get people in. Part of our challenge, we met with consumer focus groups, all the things that I've talked about, we looked at when people were calling, we weren't available. You know, our staff were dictating the intake times at their convenience, and so we had to reverse that first and make it available when the clients said they did. But more importantly, we had to be after 5. And particularly, could we get another bank or 2 of appointments after school in for children? And if we opened at 7 in the morning, could we get a bank in before school? Was that popular? So we started asking clients and families, would this work for you? We also had to look at lunchtime. are we booking lunchtime, or basically we're shut down at lunchtime, or somebody could bring a child at lunchtime out of school for lunch period? Those are the questions that we started to